talking to you first of all. I'm a CDC Associate, been asked to do this session by Amanda, been asked because I'm a nurse by background, a parent carer by experience, parent of an young adult who is clinically extremely vulnerable and has been working with CDC for many years. I'm also Vice Chair of Cambridgeshire Community Services, and I have some colleagues who are joining me on this who are going to talk about what it's like on the ground. So what are we going to be considering? The children. Which children are we talking about? I think one of the biggest complications we're facing, one of the biggest challenges is that it's not actually very clear which children we are talking about. In our first wave of shielding, everybody had a letter that were asked to shield, and therefore people knew, and families knew, and colleagues knew whether somebody was considered extremely clinically vulnerable and whether or not they should be shielding. But things have changed completely and very differently on this second time. And so there is really quite a lot of anxiety and lack of clarity. So we've had letters from the Minister. We had a letter from the Minister on the 9th of November talking about children who are clinically extremely vulnerable and the very few of them that would need to stay away from school. We've had DFE guidance exactly the same. And the DFE guidance and the guidance from the Royal College of Paediatrics and Child Health all talks about the evidence that has emerged that we've all seen and heard about, that the risks actually are very low for children and the chances of them becoming very ill are very low, even for those with existing health conditions. That's very encouraging if you are a clinician and you understand this advice, or if you are somebody that doesn't actually have a child who was considered at risk in the first phase and isn't now, and you're sitting there wondering why. And so I think this is one of the things that's happening that is really causing anxiety. So the general guidance, this is from the Royal College of Paediatrics and Child Health. Children and young people who are cared for only by their GP are not going to be considered CEV. There are a small group of children, obviously, with immune deficiency, childhood cancers, and those that we're very kind of well documented and we're well aware of, who are CEV and who are not accessing education at the moment. Then there's a further group of children, and this is the group that we're most involved in within the SEND world, children with chronic neurological conditions, metabolic diseases, a multitude of different clinical presentations. And the guidance is very much that they may have underlying condition and specialist treatment. They may possibly be CEV, but the decisions need to be done on an individual basis. In my first slide, I had talk about cohorts. We're not talking about cohorts. I put cohorts in on purpose to remind ourselves that a diagnosis doesn't say you are in or you are out of being a CEV child. It is very much on an individual basis, and then what is going to happen. I think the final thing I wanted to say on clarity and why it gets very confusing is this statement that is very, very clear from a medical point of view, but not for families. So while there may be other clinical reasons to prevent a child from underlying health conditions from attending school, while coronavirus shielding advice is paused as it is now, the small group of children who are considered to be CEV can attend school. And this is where a lot of the anxieties rise. So we've been talking when we were preparing for today, thinking this is actually very, very good news. We were expecting vast hordes of the children we look after to be really vulnerable and to not survive, and there was massive anxiety on all fronts, which is quite understandable, but actually it's not been proved to be the fact. And I've put a link on here. We'll be sending out the slides for people to follow up more on that. But there are loads of questions, and these are just some of the questions that have come out from families, which I'll leave with you to look at on your own. But these are things that have come up from parents groups, from chat groups, from service users that are coming back and asking. But I think the top one is the main one that captures all the pressures our families are under. How come my child was shielded and deemed at risk in April, can now go to school, and what's changed? There's a lot of consideration about who decides if a child is CEV, which is their lead clinician, and what happens if the family doesn't agree or they're getting conflicting advice, which we are having. Newly, adults with Down syndrome are being told to be specifically careful and that they are clinically vulnerable. But if you're a 17-year-old and you're until you're an adult with Down syndrome, you can still go to school, and that's caused a lot of concern. There's concerns obviously about vaccine. We don't have the answers to all of this, but I think the main thing is that there is a huge background for families. The last thing I wanted to say on this really, and I think it's important perhaps coming from another parent carer, is that where relationships were good before the pandemic hit, then we found that relationships have stayed good and families have been supported. Where relationships were fractured and people were disenfranchised or alienated or not involved or not accepting or felt very much marginalised by services or very much out of the loop, they're the ones that have had the most difficulties. So this is really, really, really talked about how the strength of relationships. There's been a lot of toxic messaging, and I think as a community, we need to be very mindful of that. That some of the families we're dealing with are getting some really, really bad advice from social media. I'm now going to pass over to my colleague, to Kirsty.
Thanks, Anna. As discussed earlier today on numerous occasions, what's really important as a system is that we hear the voice of parents and the reality of COVID's impact. So we received a letter sent to stakeholders from 5 families of children and young people with complex health needs, and I wanted to share some extracts from the letter with you. Can I have the next slide, please?
Bear with me. Yep.
Oh, hang on, I'm just admitting Becky. She's here. She's just coming. Sorry. So we are, as a family, exhausted beyond belief. We are working on an average of between 3 to 5 hours sleep a night. We have been left exhausted and feel families like ours have been drastically let down by the system. My mental health has taken a massive hit. In a time where it is very much in the forefront of people's minds, the mental impact that COVID has had, it would seem complex needs families have been left to their own devices to try and manage an unmanageable situation. The next slide, please. This whole situation has really affected my well-being and my mental health. I am stressed to a point where I'm finding everything really hard. The fatigue is cumulative, with each caring challenge and no time to recuperate. And the last one, the mental impact I have suffered watching my son miss out on so much and being shut away and forgotten, as well as the isolation that I've experienced, is substantial. And I'm sure you'd all agree that these are a powerful reminder of the impact of these challenging times and on families and young people and children. So I'm going to hand over now to Becky, bless her, who's just come on to talk about how we've supported the parents and families. Sorry, Becky, are you okay? Carry on.
Yeah, perfect. So what we found useful during the first wave of the pandemic is right from the word go, really, we were making weekly telephone calls to our families, which then moved to emails or video conferencing, depending on parent preference. We wanted to make sure we weren't overwhelming people, as we were aware that there may be some overlap with other services. So we then progressed to undertaking a key working role, liaising with other services so we could ensure appropriate support was offered in a timely way. Even when we didn't have the information, we acknowledged the gaps that were there. We were honest and we were transparent with families, but we reassured them that we would go away and try and find out what we can and regularly update them, and they knew that they could contact us as a first point of call for any queries that they had. Next slide, please. So a lot of our work was about anticipating what the impact of the pandemic would be for children and young people, particularly around returning to school. So really, just before the summer holidays started, we were already talking with colleagues in education, social care and other allied healthcare professionals, both locally and in some cases nationally, to find practical solutions. We then went on to formulate risk assessments, which we did in partnership with families and schools, so that we could reassure them really that we were mitigating any potential risks as far as we possibly could. And then we obviously had a role negotiating the practicalities in sorting adequate provision of essential equipment like PPE and fit testing and all of those kind of elements.
Thanks ever so much. So as a team from Cambridge Community Services, we cover from Luton and Bedford in the west right across to Great Yarmouth in the east. So we're not sitting here saying these are the answers. We're just sharing some of our experiences because our communities are very, very varied and very diverse, and the health inequalities across our patch do reflect a lot of the issues that families are facing. And digital poverty, particularly in some of our areas, say like Peterborough, has been brought up time and time again. So what we want to do is use the time to discuss with everybody else what you've been doing and what you've been solutions. But we have got our DCO Siobhan with us from the Cambridgeshire area. So she kindly said that she was going to kick us off with some of the work she's been doing as a DCO to look at how we might mitigate against a lot of the challenges that these families are facing. And we haven't even touched on, but it has been touched on in the plenary, about the social context of all the families that are working with, not just their health. Thanks, Siobhan.
Thanks, Anna. So one of the areas we looked at in Cambridge and Peterborough is we were really aware before the complaint, the 5-family complaint came in, actually, that children who were deemed clinically extremely vulnerable that the parents were tired. They were really, really struggling. Right from April, May time, we realised that we would need to step up some overnight short break services for those children. Our overnight short break services in Cambridgeshire and Peterborough are commissioned by our local authority, and the CCG part fund that. But we realised that some of the children's needs were so extreme that some of those services would be disrupted, but also our training and our clinical supervision services were also disrupted because of redeployment of staff. So we used some COVID funding to work with our local hospice, Milton Hospice, and we created a 6-month COVID response service called the Milton Hub. What we've done is we've used mutual aid across the system. So we partnered with Cambridge Community Services, with the CCG, and with each, and we have other kind of providers coming on board as well as the project has kicked off, and we have quite our eligibility for families to use this service is not dependent on them being known to each. It's not dependent on children having continuing care or palliative care needs. What we've said is it's children who have clinical care needs where it's sometimes quite difficult to set up care packages for them. Those care packages have been disrupted, or their usual family network of support has been disrupted. So those are our key eligibility criteria. We opened our doors a little later than we'd anticipated because finding the workforce to man this was tricky. It's been very difficult. Our workforce resource across the area is depleted and is not very big anyway, as I'm sure most of you know. Working in children's services, we're not a huge group of people, to be honest, to be providing quite large area services. So I've just, the next couple of slides is just we're using parent reported outcome measures to really try and understand what the parents need, and it echoes from the complaints, it echoes from the feedback we've had from families, from the national feedback. The families are really tired, they're absolutely exhausted, and what we wanted to put in was 3 or 4 night blocks of breaks. So we've just about to complete our 3rd, so we kind of open every other week for 3 or 4 nights, and what parents have been feeding back to us is that actually having a sustained break rather than just kind of a few hours or a one-off night, having 3 or 4 nights as a block has created a proper rest. And that's already the feedback we're getting is, this is what we wanted to do while we had the time off, and this is what we did, and it was really good. And most, in fact, of the 7 families that have fed back so far, they've all said that they managed to achieve what they were expecting to with their break. So it's been positive so far.
Thank you ever so much. As I say, we will be sharing these slides, and we have, of course, permission from all the families to be quoting them anonymously. I'm going to stop sharing the slides because it's nice to be able to see everybody. And what I really want to do is ask people to share what they've been doing. Questions or suggestions, not just anybody. If you want to show up a hand, and then we'll invite you in. Are there some comments in the chat box you'd like to bring up, Deborah? You're on mute.
Can you hear me now?
Yeah.
Sorry.
No. Still on mute. Yes.
Good.
Now, okay.
Lindsay Manley,
Yes, I'm here.
it'd be
Not on
quite good
camera.
if you could share. You had a long message there on the chat.
Yeah, I just want to reiterate, really, I think it's been really, really tough, and but our team didn't stop working. We were really fortunate. I take my camera and they can see me now. Not very well though. We weren't redeployed, although there was some discussions around that, and we managed to keep the service going along with the children's community nursing team. Our special schools remained open, and although they did have limited children during the initial first months, they increased that pretty quickly. So my nurses were they were in full PPE, and trying to support those families in. The schools were really innovative as well. They did walk-in lessons, went and picked the children up and went for a walk with them if they lived sort of near the school. They also went and delivered packed lunches to those families that were who are, deprived, or who would be entitled to free school meals or things like that. So and they remained open through I think they only shut for 2 weeks in the summer holidays, and were open all over Easter and the half term in May as well. So I think it was unfortunate that our hospice unfortunately did close its doors, as did some other respite services. Part of our service, we have 2 nursery nurses who provide respite, and once we got them fitted in and sorted out with their FFP3 masks, because some of these children were needing suctioning, they were able to then extend that respite for those children that couldn't return to school because of the AGP guidance as well. So yeah, I'm really proud of my team.
Brilliant. I think we do need to celebrate, and I think it's one of the reasons why I asked colleagues to join me and to get Kirsty and Rebecca, because they have worked so hard and so imaginatively and so creatively. And I think the message that I was getting from Siobhan joining us, that this is a system approach and system working, and it's really nice. And I think people really need to celebrate what they've done, and I'd like to say thank you on behalf of the parent community for the enormous efforts. See, Christine.
You got your hand
up. Hi, thank you. So I'm Christine Sketch. I work as an educational psychologist, and so really this area of work is not absolutely central to my day job, but I've got some questions really, because my focus is very much about kind of the quality of multi-agency collaboration and the manner in which agencies are working together. And I'm hoping, and hearing what people are saying, I'm hoping that there's been a sense of improvement of collaboration and coordination between services across the pandemic. But I suppose I would really welcome reflections from round the virtual table to say whether or not it's felt very much single agency led or not.
Right, I'll pass over to Kirsty, because we have noticed a considerable step up in this. Do you want to? And then we'll open it up to everybody else, of course.
Probably Siobhan and I could talk forever on this, I think. I mean, from my point of view, it's dramatically improved the way that we joint work. I have some carers that offer respite care for children with continuing care needs, etc. And they're now working at the hub that Siobhan was talking about under mutual aid, and it's been fantastic. The opportunities to share learning, training, that joined up working has just, I mean, Siobhan, I'm sure you'll agree, I think it's pushed us into a world where we've had to work better together, and that can only be a real positive. The same with the acute hospitals as well, if to mention those. I feel generally across all the systems we're working so much better together, and that can only continue as far as I'm concerned.
Thank you. Yes, we've had some more comments from other areas, so I don't want to hog it into the east of England. Who else was wanting to speak about this in the chat room?
I'm Rachel from Children's Social Care and Early Help, and I was just being proud of my my service.
Great.
The feedback from our families, we're a tiny, it makes me sound like I'm from the whole of the City of London. I'm not. It's the square mile, the tiny little bit with Tower Bridge and St Paul's. But our social workers were out visiting, taking young people out and about, dropping off food. We got dongles and laptops to every single one of our children and families within 5 days of lockdown. One of my social workers got in her car and got the last 5 dongles across the Greater London. It was brilliant. So just very, very proud of the innovation. We changed our short breaks policy within 2 days of lockdown to enable families to spend that money on indoor and outdoor play equipment, apps and iPads and laptops. We're changing that back at the end of December, so we didn't change the amount of money. We just recognising that some of the respite providers weren't opening. So the games and equipment and a lot of Lego has been bought, it has to be said. And we've just done an annual survey of parents, and 94% responded, and there was a 100% satisfaction rate with social care and early help. So it's just been a really innovative thing and a pretty great feedback from social care. Sometimes social workers are a bit maligned, but the families were very, very, very grateful. So just really innovative, creative practice with social workers in people's homes the whole time. So that's me. I've got pink background because I was at a baby shower for one of my colleagues earlier and I haven't changed it.
Oh, lovely.
Maybe I should leave it up.
Some more comments from anybody else from other areas?
There's a comment from Marie in Newham around joint working. You're still there, Marie?
I am, yes, hi. Yeah, I would agree with the sort of suggestion that joint working has increased. And I think somebody else also said that the virtual working has really helped that. So use of virtual teams, no one has to travel anymore to do that. So that's been really helpful. We had weekly, we went to twice weekly, we stepped back down to sort of fortnightly, we're back at weekly meetings, just where everyone can pop in and talk and share what they're doing, what the pressures are, updates. So that's been really helpful. But particular to extremely clinically vulnerable, I have heard this from other areas as well, we've really struggled to get that list. And I think that is something we need to reflect on and think about going forward with regards to information sharing. We still haven't cracked it, we are trying it, but we really haven't managed it, and that's caused our DMO quite considerable concern of not knowing who's on the list and then, you know, how to advise families accordingly. And I just wondered if anybody had any, you know, good news stories about how they'd cracked that.
We've got a working group this afternoon of DMOs and DCOs looking at this. Unfortunately, it got scheduled for this afternoon before this discussion, but obviously some of this will feed into that as well. I think the general consensus, do jump in, Siobhan and others, is that it's not been cracked, and this is one of the group of children that are most in danger of being disadvantaged. It's nice to meet you because we're Twitter contacts and I've never seen you before. So, Siobhan, do you want to come in here?
We've certainly struggled in our area to get an up-to-date list because there's so many people, so many different clinicians inputting into that list. There's so many different perspectives from family members, from GP perspective, clinician perspective, and I think that for me it's more about what's the impact of being on the clinically extremely vulnerable list. Because if it's a negative impact because there's a belief that the child shouldn't be at school or they shouldn't be supported, then that's an issue. So to me it's about, yes, there needs to be the clinically extremely vulnerable list. However, we shouldn't have any sort of blanket policy around how those children are supported or back at school, because a need is a need, whether you're a CEV or a moderately extremely vulnerable or not particularly extremely vulnerable, but as a family you feel your child is, we need to be able to flex and move with those, those different thoughts and perspectives and not go with blanket policy. And I think that's been an issue initially in the first wave, certainly in our area, around school attendance. And we're still seeing some of that now where school, if a school says, well, we can't because the child's clinically extremely vulnerable, they shouldn't be in. We should be using our multi-agency risk assessments much more intuitively than that to understand the needs of the children and make sure that those who are really vulnerable for other reasons, not just their clinically extremely vulnerableness, but the other vulnerabilities that these children do have, that we don't forget those bits. So that's what, because I'm not sure we ever will get we haven't got a function that will give us this kind of one-off list that I wonder if we're chasing something that can't exist, so we have to maybe think about it slightly differently.
Can I just
sorry, Deborah,
just briefly returning to the east of England, sorry, I think Rita Jenner from Suffolk had a couple of comments. With one question as well about COVID testing, Rita, if you're still there.
Yes, good afternoon, everybody. Yes, you know, we're talking about what's happened in the first lockdown, but actually my concern is that there's now starting to become a bit more evidence. I'm part of, I've just seen some literature this morning sort of highlighting that actually schools talk about schools being super spreaders of COVID. And I think that there is a concern that following yesterday's announcement with Matt Hancock wanting some schools in Essex and Kent and London to be tested because there's such large outbreaks. As a parent, you know, I would imagine that makes them quite anxious if your child is clinically vulnerable, because on one hand, the shielding list is saying, you know, unless you've got a very set few things, you know, your child is absolutely perfectly safe to go to school. Yet there is a massive increase in schools, and there is a real starting to be evidence. I was reading, like I say, sort of research that's coming out from Germany and from the Czech Republic and Australia about how schools are the silent super spreader. And so this is starting to sort of surface, and for parents who are concerned about the children who are being extremely clinically vulnerable, I would imagine that this is a very anxious time. And I think, you know, we've obviously had all the things that have happened in the first lockdown, but I think actually we could be potentially facing some issues sort of upcoming if this continues.
I think so, and I think teams are getting very wary. Parents are getting very wary. I think that the danger at the moment, and certainly psychologically, and I've felt it even, that I've kept my son alive since March. If I can just keep him going alive until he gets his vaccine. And so the pressures are kind of ramping up. And so I'm getting more and more kind of risk averse because I've nearly got there. And I think this is reflected with other families that we've talked about. He's an adult, it's different. He's not in education, he lives in a residential home. So lots of other additional challenges, but I think it's really important to think. I think some are also the families we need to think about are the children that aren't clinically extremely vulnerable as regarded by a clinician, but the families think that they definitely are extremely vulnerable. And I see Anne's come up. Yeah.
It was leading on from what Siobhan had to say, and I'm from the northeast of England, South Tyneside and Sunderland. We've been having meetings between a lead social worker for children with disability and head of service and SEND and myself from health to rag rate and triangulate the information regarding individual children as to the risk, including parental information as well, as best we can. Just thought I'd mention that. You know, we thought that would be the way forward.
Yes, thank you very much. I'm very mindful.
Worked in our area, definitely, and that's been a really, really important part about that rag rating, and that's all coming together so that we've got as much information as possible, even if we haven't got kind of up-to-date lists. So that's really, really positive.
I'm very mindful. This is a really rich conversation, and we don't have much more time. Becky Bedford here has developed and shared a risk assessment through a lot of children's community nurses that we will attach when we send out the notes from this, and also a WhatsApp group from people that are that she led on and has set up, that a lot of people from the community, and it's not just stuck with children's community nurses, but we'll put those in the chat as well. And if other people have got things that you would like to share with us, please send them to Deborah or anybody else's contact you've got at CDC, and we will gather this and send it out. I see Rachel is typing. If you want to talk, it's been quicker.
No, I was just saying thank you, that's really useful.
No, that's great. So sorry to cut you all off, but we're all supposed to be finishing and then going into our next workshop.
Yes, I'm sorry about that. We will all have to leave this one and enough time to kind of go to the next one. And for Becky, Jill and Siobhan, that will mean like just clicking the link for workshop 2. Yeah. Thank you.
Thank you ever so much, everybody. A rushed but important discussion.
Thank you. Bye.
Thanks.
Thank you.
Thank you.
Thank you.